Okay, folks, welcome back from lunch. We're now going on to agenda item number 9, which is the draft carer strategy, and we've got Viv who's come along and been waiting patiently to engage us all. So pass it over to you, please, Viv.
Thank you, Chair. So yes, you have the draft strategy in front of you. Obviously, this has taken a bit longer to come to you than anticipated. We had expected to get this done for you a bit early, but when we had gone and had some conversation with carers again, and I've revisited the survey information, that's when we came up with that phrase of more of the same won't do. So wanted to revise the draft strategy to very much reflect that as a feeling around what's here, and this is very much based in that lived experience of people who have that care role in Dumfries and Galloway. We really looked to base this around that identification of carers, recognising how important that is, and also the carers' rights, which we all know and understand our responsibility. And I think it's probably fair to say from what we've looked at that we could probably do a bit better as a health and social care system in order to support carers and recognise just how important their role is. So we're bringing this to you with a promise of a really funded and kind of costed out delivery plan. And that's going to be developed to kind of reflect the 4 C's that carers, we went back and asked carers to tell us what would be the things that would be most important to them, given that where we are financially. Katie wanted to make sure that what we were going to do was be putting our efforts and focusing our resources in the places that carers themselves are telling us is going to make the biggest difference for them. And that's on that page 2021. Now, while the 25-26 budget and beyond is not known yet, we know that the Scottish Government have announced some additional funding for supporting carers. So we'll wait to see where all of that comes, and we're planning to get all of that together to bring back to you on the 5th of March. What I think was really interesting is that what carers have identified as the things that make the biggest impact to them is actually implementing and doing better in our existing processes, and really making sure that our practice is following what we say and what we've got in place. So I think that's going to be the challenge for us going forward, is about how we're going to do that from there. And we've been working with carers and carer support organisations and professionals across D&G to try and put that into that delivery plan. But what we've done is, in that very last section here for you, is put in what it is that they've prioritised for us, the carers, what they've told us, and it's about that acknowledging their lived experience, involving them and identifying them early. So that kind of fits with what we've described in the strategy. And they want to really want to make sure that people that are delivering health and social care, so our staff right across all the different sectors, are recognising and valuing carers and understand their rights. I think there's a feeling certainly that that's not what they're experiencing at the moment, and that short breaks, which we know we've been hearing that for some time about that from there, and I'm happy to say we've got some things and proposals in the pipeline that will feature in the delivery plan for you. And Rebecca and I have had a conversation about doing some work to bring some of that forward too, and about things being accessible to people regardless of whether they are registering or identifying themselves as a carer or not. If you need the help and you need that support, then you should be able to access it, I suppose, is the feeling around there. So we'll bring that back to you in March. I'm working closely with Sean and the finance team to pull that together, all kind of costed, and our carer programme board around getting that together for you. But really asking you to approve this as your legally required carer strategy for Dumfries and Galloway, and we'll press on with not doing more of the same, I suppose. And very happy to take any questions.
Okay, thanks for that, Viv. And clear as And whilst it may be legislative and a requirement, we could just put something out, but you haven't. You've done a great deal of work. You pulled it all together, and thank you and your team for doing that. Gosh, I'll go to Mark first and then Greg.
Yeah, thanks, Chair. So I've just got a few points that I want to make around this. So first of all, I just want to call out page 15 makes reference to the carers hub, and I just really wanted to call out in this space the work of Mark Adams in developing what is a really robust hub that he's led, supported and developed that and really built up on that. So I think it's really just to call that out. I think for me, the title, it talks about carer strategy, and I don't think it makes it clear, although the document itself makes it clear that we're talking about unpaid carers. I think we should see that within the title, that we're actually talking here about unpaid carers and not paid carers. I think it's important that we make that differentiation really early within the strategy. I really like the fact that there's so what measurable outcomes. I just wonder, should we be a bit stronger in our strategic direction around this and actually calling out what is our actual strategic intent around this? What do we hope that the endpoint's going to be? When you look at some of the stats, are 72% not accessing support, 61 saying they need support, 71% really feel that others understand. Is our strategy going to go underneath that? So does our strategy align with the fact of what people are saying? And I really like to see something about how we interface the care services and the unpaid care services as well, and how our strategic intent is going to really intertwine some of that stuff as well. So I know quite a lot of points to be made, but that's my thought as well.
You want to come back in that bit?
Yeah, I suppose really grateful for the feedback, Mark, and I mean, I think absolutely acknowledge what you said around the carers hub, but I think we need to recognise too that that's not purely on our NHS and our member staff. There's a lot of input from our third sector partners around that, so I wouldn't want to miss them out in that kind of thing there. And in terms of that kind of unpaid carers, I'm happy to go back and look at that again if folks think that's there. I mean, it does say quite early on in the introduction about that it's for unpaid carers, but we can see it, although it's not in the title, but that's there. And in terms of our strategic intent around some of that, the IJB of course has got a strategic commissioning intention around carers, and also our main aim around this was really about the delivery plan. I wonder if you're going to see that much more in that delivery plan, Mark, rather than within carers that strategy. And I guess trying to kind of embed this within the lived experience of carers is what we've really tried to do here. But I'm really happy if folks want me to revisit that and look at that again. Very, very happy to have that, to take that other look at that there. But I would hope that when we get the delivery plan for it, when you're going to see much more of that, Mark, in terms of the what are we going to do about it?
I just wonder if we should call out something about the cultural shift that's needed within that space. Perhaps that's, it's missing under some of that is actually we need a cultural shift in order for us to be able to embed carers as part of the wider caring team.
Okay, thank you.
In relation to the unpaid carers part of it, I mean, clearly what you've done is you've aligned it with the Carers Scotland Act, and that's why it's, they don't call it the Unpaid Carers Act, so I don't know. Just for consistency, it might be.
Yeah, and there's actually quite a lot of controversy, if you can believe it, around using the term carers, because a lot of unpaid carers don't like that term. They don't want to see that. I'm a wife, I'm a daughter, I'm a son, I'm a husband, I'm a friend, rather than in that caring, and it's more about that caring role, I suppose. But folks have got preferences, I suppose. But yeah, thanks, Jim.
Greg?
Yeah, mine was just a minor point, just to remind everyone, my update earlier that this has been to the Strategic Planning and Delivery Committee, where we discussed it, and our recommendation to IJB was that this is endorsed. So just to remind everyone that it has been through.
Good point. Good point.
Yeah, my comment really, I guess, is more for the delivery plan rather than the document, and it links back to our early conversations around early intervention and prevention, and I think there's a real opportunity around looking after supporting carers, and it's in there around respite, and what have you. Maybe this 20,000 roughly people could be a real priority for us.
Yeah.
Piloting sort of different approaches around prevention and early intervention,
Yeah.
because it seems like a really obvious place that supports the whole system.
No, I think you're right. William, and some of the proposals that we're looking at is when I first was having conversations around that within the operational space with colleagues, we were looking at folks who were on the portal as requiring kind of respite around that from there. And I think it's back to what Rebecca was saying earlier about actually by that point, that's getting too late for providing that support for care to continue in their caring role. It's got to be much, much earlier if we're going to see that impact. By the time they become known to services, are eligible for the kind of support that goes on to the, it's by that point, they're almost at that crisis, if not already beyond it. So it is very much about how we do that earlier. And I think you're absolutely dead right around this is about our practice. We've got lots and lots of process around how we support them, how to support carers, what we do to support them and how we encourage them to do so. But I think there's a gap between what we're actually doing and what they're feeling on the ground.
Okay. Rebecca?
Yeah, thank you. I suppose I just wanted to, just touching on what you said there, I think when we look at the preventative, carers prevent so much access to statutory services, and I think that we really need to take cognizance of that, because that we're talking billions, and I think that it's important to recognise that and to build on it in terms of actually, so the training that you would provide to carers and different aspects that you would provide to carers that wouldn't necessarily cost us any more money, but would enable them to continue. So.
Okay. No?
I think.
Okay.
No, I was just going to say, I'm almost going to go so far, given that you like the more of the same won't do, and I might go a wee bit further and say that, within that financial conversation that you were having earlier and around that from there, there's almost a bit of, if you only do one thing, I think supporting carers to avoid people reaching those crisis points, that would be a plea from me. Now, albeit that I'm totally immersed in where we are with that carers agenda, but I do think you can't underestimate how much of a impact it would have if these folks are not able to continue in what they're doing.
Thanks. I had conversations with some carer support organisations over the last couple of weeks, and I suppose just important to note that the strategy is welcome and I think has drawn out a lot of the feedback, and that speaks to the level of engagement I think that's happened across the board, which is great to see. Yeah, but like William, a lot of the questions and feedback I'll hold back because it's related to the delivery plan. There's a very keen interest on how ambitious will this be, how different will it be than has gone before, and a number of those priority areas everyone will recognise in the room are not new. They're surfacing slightly different ways and backed up by some more data, but they're not issues, so they're new matters. So yeah, I think one overriding theme that's been touched on already is around how people see themselves in terms of provisions of care, as to whether they're a carer or not, whether they're a family member, and the idea of having to move into a kind of recognised group, if you like, in order to access any of the support is actually quite difficult for a lot of people who wouldn't see themselves in that way, but also does become a barrier because people don't want to move themselves into a category in order to access the things that they need. So I think that a welcome component of the strategy was, and you can see it in the priorities, the 4 priorities there is, was that this should be about for everyone. If you identify that what you're doing could be in a caring role, here's access to the information and support you can have, rather than requiring people to identify first in a set of criteria before you get access to the information. So more just to say, I think across the organisations I spoke to and the representing carers, that this was really welcome and a strong view that reflected exactly what they think needs to happen. But there's a wait now for how that translates into a delivery plan. I think which has been a lot of feedback.
I think it's helpful to know that, isn't it? Yeah, because it shows that the work you're doing with engagement is getting through as well.
Yeah.
Nicole?
Yeah, I just wanted to kind of touch on one, just to echo what everybody said, and just absolutely commend this work and what a key baseline it is for us, because if we don't do this right, what is the point, So I absolutely just want to commend the work, and I'm really heartened to hear the kind of feedback from the likes of Alan and others about just that level of engagement with people with lived experience. Just in terms of the bring forward in March and that really important to the implementation plan, I think building on the learning about directions and that kind of comment about the fact that, you know, none of this is particularly new in terms of the priority areas. So what is going to be different and really thoughtful, the right care, right place direction, David, and what we're going to measure is impact in 3 to 6 months, what we're going to impact in a longer term, and actually having something really tangible that the Health and Social Care Partnership need to work to deliver with partners, and reporting that up to the IGB in terms of that performance. Because if that is that real one thing that's going to make the biggest difference and avoid that billions, how do we actually measure the impact and actually put activity where our mouth is, really, if that's the same. So really, really keen just to kind of preempt that work and not comment in March about that, but I really think we need to use the direction process now that we've built that to really drive that change, including the cultural change that Mark kind of alluded to.
Okay. Vicky?
Just wanted to comment on that point Alan had made just there about carers maybe not wanting to kind of acknowledge. I certainly, I mean, I have a lot of contact just because of my own caring responsibilities. I have a lot of contact with parents of young people with neurodiversities, and really a common thing is that actually people didn't really want to sometimes acknowledge. They don't really want to step into the realm of diagnosis for a fear of that negative impact on their lives and on the lives of the young persons. And actually, if you do step into that realm, actually for the young person, there's a whole load of positives by getting what they need. But there is that real fear of actually this is going to be really harmful. And I think that's a societal thing that, you know, people are less valued, and you know, that's something that we should definitely try with an opportunity like this to try and dispel some of that. But actually there are positives in actually stepping forward and acknowledging how you are or how your child is.
Okay. David?
Yeah, thanks, Chair. And I just wanted to pick up on Nicole's point about the specificity that we'll have in the delivery plan that will come forward in March. And I think that is the opportunity, Nicole. I think you're absolutely right. I'm just going to come in on Mark Mady's point. That is the point to quantify what we expect the impact of those actions to be really clear around the timescale for delivery, and also to describe quite clearly how that culture change that Mark alluded to will look very different for us. So I think the detail piece will come through, and I think the direction that we issue on the back of that in terms of delivery needs to be really clear, so that those measures are there within that direction, so we can begin to assess the extent to which we're actually realising the impact that we need to have through this strategy.
Yeah. But I think we get there with directions anyway, so I think, you know, the processes that we're embedding are over that. Okay. So are we okay as a board to approve this and pass it forward? Okay, thank you. Thanks, Viv. Thanks for coming on. Okay, moving on to item number 10, which is winter plan preparedness. Kirsty, I believe you're going to sort us through this.
Yeah, we have circulated round the presentation, so I don't know if you've all got it up, so I'll just take you through slide by slide. So please, this is quite a lengthy presentation by way of a warning, but it is very visual. You'll just hear my dulcet tones.
I'm just wondering, we've got some visitors at the back. Can we invite them to come and sit beside somebody and see this if they want to? If they want to.
They can, yeah.
If
You come and sit behind me here.
we could either sit there and look at Alan's and one sit and look at.
Mine's teeny, if
Oh, right, okay. We'll sit next to you. Sit anywhere, really. Yeah, you sit there.
Great. So, I mean, essentially, this is for assurance in terms of a lot of the plans that we've got in place across the partnership. And over the last number of months, you can only imagine the significant amount of work that's been undertaken to ensure our partnership are working to streamline processes and improve our patient flow through our system. As we get us to a better place ahead of winter, and I say ahead of winter, we're in winter now, and it still continues to feel that we're continuing to be in winter, even in our summer months. So it's been a very difficult year for the teams, and I wanted that recognised, especially the kind of front line with that relentless pressure on teams. And through the work that is being done, it's hoped that at least some of these pressures are being alleviated by some of these improvements and support mechanisms that we've got in place. But it's undoubtedly going to be a pretty tough winter that we've just moved into. So slide 2 essentially just gives you a bit of key learning that we did a debrief around 23-24, and that was just held in March 2024 to identify kind of key actions and learning points that could be implemented ahead of this winter, even though we're in it. These actions and learning points have been addressed throughout the year, and that was about identifying priorities. So that is a bit about, rather than spreading ourselves too thinly, that we actually identify to do good on some things and do them well. And those kind of key areas, as we agreed at an unscheduled care steering group and validated by our leadership group, was discharge to assess, and I'll go into that in a little more detail later, and discharge without delay, which is a focus both for our acute colleagues and cross-directed as well in terms of mental health and community. So it's that real together working with each other. There was also the significant, and we still hear about our housing delays as well, and during last winter some of our longest delays were due to the inability to obtain suitable housing. And unfortunately we do remain in a similar position. However, we've started to build better links in with our colleagues across our independent housing organisations, so we can work in that more collaborative way and resolve challenges where we can, as quickly as we can. And we have got a short life working group in place monitoring all that at an operational level. Data, well, data, there continues to be challenges in accessing data and obtaining real-time data in terms of how we're operationally running, specifically some of our kind of community-based practices, but we're continuing to strive to make those improvements and get our systems much more integrated in terms of that operational reports. And also for assurance, public holiday preparedness has always been a kind of bone of contention of those who understand being execs or general managers on call, and with the local authority as well, about how far in advance and how we've got our contingency plans in place in terms of making sure we have that adequate cover over the festive period, specifically our public holidays. So slide 3, the 14-day length of stay, essentially it was identified not only as a winter debrief, but later in the year by colleagues from the Centre for Sustainability, which is a national forum, that a key focus should be on those people who have stayed in hospital longer than 14 days. And given the impacts of deconditioning following long stays in hospital, our acute colleagues have a review system in place to ensure they're focused on these long stays, but noting again those challenges in terms of housing, etc. Another part, and we talk about digital all the time, but we do need to make sure that digital is a key priority moving forward, and we do have our digital delivery and plan in place, and we continue to monitor that through our steering group. But for future, I think we could be bolder in terms of the use of technology and how it supports people in their homes. Interim beds, we continue to monitor and manage our interim beds, and also continue to follow due process in terms of those flexible beds through that Right Care Place programme. We have got escalation and surge plans all in place as part of our pandemic plan, but just at those times of surge, we have got all those escalations in place, and we know we've got all our kind of command control structures there too. So in terms of actions and learning points identified in last year, I hope that does provide members with some reassurance that we've taken that on board and done that winter debrief from last year and taken it into this year. So essentially, as part of our winter preparedness for this year, we have to complete a winter checklist on an annual basis, and all you see in front of you is essentially the overarching principles are resilience plans, like business continuity, comms, step up, step down care, urgent unscheduled care, planned care, digital, primary care, prisons, social care, workforce, and seasonal outbreaks. So we have formally responded to Scottish Government as do other boards in terms of that. And this is a very NHS driven, but we do ensure that we capture that social care working across our community, mental health directorates, etc. So next slide is essentially about communications. I think communications is absolutely key over this period, and it is that home first approach and no place like home are the quotes taken from Scottish Government communication toolkit for this winter. And we have got a local comms plan for winter, which is in development, and we are starting to disseminate some of those communications, not just inwardly to our own staff, but also outwardly to the public. This will all include our national materials, but it is vital that we ensure our public comms are local and relevant to our population. It is also important that we provide the public with honest and accurate information before any visit to hospital, and this will help kind of set those expectations and hopefully help relieve a little pressure on our teams. In addition to that, there's also some excellent partnership working that we need to recognise and celebrate, and this will likely again be another difficult winter for our teams. So it's essential that we actually put some of those positive messages out there, because we know there's lots of positive work going on. So just moving on to slide 6. So this is primary care. So essentially we have got that professional to professional advice in place across directorates, and further work is already underway in terms of strengthening and developing these links as we move into the new year. We have got our out of hours processes in place to make sure that we've got adequately staffed rotas with out of hours for GP and AMP cover, and we've also currently aiming to bolster out of hours provision over those public holiday weekends, because they are some of the times that we see greatest pressure in the system. In terms of dentistry, we continue our emergency care pilot, which is ongoing, utilising our dental practice individuals as well. And we know that GP practices will be closed over the public holiday, over the Christmas week and New Year week, but colleagues are working to understand the provision that will be available both for routine and urgent need, and this will be communicated to the public to keep everybody informed as such. Community have never routinely covered Christmas Day. However, a list of provision that is available from community pharmacy is being compiled, which can be shared publicly around as well as part of that comms plan. In addition, this information will be shared with NHS 24 to enable them to direct people to the appropriate places for support. So slide 7, in terms of mental health, we have got a blue light mental health pathway in place. This has been in place since 2023 and provides that pathway for Police Scotland and Scottish Ambulance colleagues to access mental health advice and guidance to allow for effective and equitable access across mental health services for people in our communities. Access to our crisis team is also available 24 hours via professional to professional referrals or through GP out of hours. The crisis team now also have a base in out of hours overnight, so they're close to the emergency department to provide and support intervention in a timely manner to avoid people staying any longer in the emergency department that is needed. Home-based treatment is also offered by the crisis team. A person would have an assessment at home and interventions provided before an admission to hospital, where the team are able to manage the risk. This is to try and keep someone at home for as long as possible, so that hospital admission is the absolute last option. The team will also then facilitate that early discharge home, and so that the person can continue their assessments and early rehabilitation period at home rather than in that hospital environment. Fit to Assess is another scheme. The team are currently working in collaboration with colleagues from the assessment unit in DGRI to develop a process whereby a mental health assessment could take place with a person whilst they're still receiving medical treatment, rather than waiting until this is complete. By dovetailing the two processes, it will aid flow and ultimately provide the person with an improved experience. So the next slide is women's, children's and sexual health services. So within that team, the team are working with public health colleagues about RSV and flu immunisations to continue to provide education and delivery on that programme for any high-risk pregnant women. And in addition to this, within paediatrics, we're currently in the process or have reviewed those pathways in terms of respiratory care as well, so that we're in that place ready for those admissions. Moving on to slide 9, I'll not really go into any of that. These are like our support services in terms of having 4x4 capacity, in terms of weather, etc. Having our ICES in there, and our general kind of logistical and support services are all in place, and we've received assurance from all our teams on that aspect.
What are ICES?
So,
Equipment.
yeah, equipment, sorry, yes. I just expect people to understand. So slide 10's health protection team. So the health protection team respond to instances of notifiable diseases and outbreaks of concern. They also provide advice and arrange a setting and disseminate alerts as appropriate. So in preparation for winter, the health protection team have been supporting the care home tactical team with infection prevention training for care homes, distributing winter packs to care homes to ensure they can respond quickly to instances of illness, and preparing a winter newsletter for care homes as well, and monitoring national and local surveillance and sharing with colleagues as necessary. So just moving on to winter vaccination, slide 11. In terms of the vaccination, the team recognises the importance of vaccination as a key primary preventative measure. Our performance across all vaccination programmes is strong and protects our population. In terms of the winter vaccination update, we have historically been one of the highest performing mainland boards, and our delivery programme provides equity of access for winter 24-25. We are delivering well in terms of the ongoing flu and COVID programmes, with a slight increase in individuals opting for flu only and not taking up that COVID vaccine. These programmes have been promoted with dedicated clinics and peer-to-peer vaccination offered to eligible staff. And despite this, staff vaccination rates remain lower than we would prefer, but still above that national average. And there are some drop-in clinics that I'm actually attending myself on Thursday. We've implemented the new RSV vaccination programme for those aged over 75 to 79 and pregnant women. An uptake has been again above the Scottish average across all eligible categories, representing significant protection against this seasonal virus in our population. So slide 12, as part of Right Care, Right Place agenda, work's been undertaken to commission the flexible beds within the care homes across the region, which I noted earlier, and again the monitoring and management of those interim beds as well. And we have seen reports coming in through our partnership meeting on that. The care home tactical team have done a significant amount of work alongside our care homes over the last few years, and part of that work was to reduce the number of admissions or attendances, should I say, from care homes, and the team have successfully achieved that. And it is a fantastic achievement that the team have been working collaboratively with our care homes their staff and the residents to reduce that number further. Okay, next slide, care at home, in-house service. So we have got our business continuity plans in place for care home, care at home service. I'm getting the two mixed up. So our in-house service CAS have preparations in place ahead of winter by way of business continuity plans, business impact assessment, and graduated response implementation plan. These documents and plans set out to consider the vulnerability of critical and essential activities across a number of scenarios, such as the loss of IT, loss of power, data, information, etc. All areas covered, mitigations and further actions for consideration. The team have had a cause to initiate these plans very recently due to the inclement weather, and are pleased to report they worked well and were able to de-escalate and return to normal in quite a short time frame. So moving on to discharge to assess, and just as I said I would explain that further as one of our key deliverables. The Home First approach in Scotland emphasises the importance of recovering at home once someone's medical treatment is complete and they are medically fit for discharge. It brings together the different strands of support needed to allow this to happen and maintain a person's independence. As part of this approach, we implemented discharge to assess during October, with the aim of delivering the most appropriate levels of care and support for people across our region. By way of change, this means people will continue to have a baseline assessment within hospital. Those people assessed as clinically ready to go home will be safely discharged with an appropriate level of care and support. Following discharge, the person will be supported at home via our reablement team, CAS, or our provider partner, and this support will remain in place until a full assessment has been undertaken in a person's home. The person will receive a full holistic assessment within 72 hours of discharge, and this will allow for a more accurate assessment of need rather than an assessment in an inpatient setting. This will also ensure that people are getting the right level of support, helping them to have independence and maximising our scarce care at home resources that we've heard discussed earlier in this meeting. We also have a community flow hub which is fully operational, processing all discharge to assess referrals and working in collaboration with the reablement team, home teams, provider partners and others. We are still in the very early days of this new process, and of course there have been some operational challenges along the way. However, the teams are working collaboratively and working together to resolve these. Only 3 or 4 slides to go. Slide 15, discharge without delay. So moving from discharge to assess to discharge without delay. This is also a national programme of work which focuses on that good discharge planning and optimising that flow through our system. The acute team have taken 4 key areas of focus and developed an action plan to scope where improvements can be made to improve that flow. We're undertaking several pieces of work to understand the challenges and blockages to discharge, reviewing people who have been in hospital greater than 14 days, carrying out an audit to understand what improvements can be made in terms of patient transport, developing a project called What Are We Waiting For? To ensure that each day someone spends in hospital, a positive step is taken forward in terms of their discharge, and also aiming to achieve a 5% in reduction in our length of stay in our downstream wards over the coming year. In terms of the time of day of discharge, the aspiration is to work towards movement much earlier in the day to ensure flow from our front door areas. By doing this, we'll hopefully see an improvement on our time of day of discharge. We relaunched our discharge line back in September, where people may still be officially discharged from hospital later in the day, but by using the discharge line, this essentially allows for that earlier movement of people from the front door to downstream areas. So we're not having that bed blocking issue. The team are aiming to work towards 10% of patients transferred from assessment areas to have critical lead discharge in place. This is a low starting point, as initially the focus will be around weekend discharge planning. And that is discharge without delay. So now hospital at home, slide 16. So there are a number of areas that sit within that hospital at home space, which includes frailty, OPAC, respiratory, integrated team and cardiac rehab. The hospital at home series of projects will look at the great work already being done by these teams operationally to see how we can build on our current good practice. And all of these projects will explore that early supported discharge, as well as how we can support people to stay at home and avoid that hospital admission where it is safe to do so. Digital innovations, given the rurality of our region, it is important that we consider other ways to support our population, and we continue to utilise, where possible, our smart hub called Ethel, and doing this via our discharge to assess model of care. The teams will start to think about that digital first approach, and we're continuing to work with our provider partners who are also keen to be involved and promote the use of that smart hub technology. So thank you. You'll be glad that's all those slides done. So you can see a significant amount of work has been undertaken across the partnership, and I think actually this presentation's gone quite viral this year across a lot of, be it in the local authority, we've seen it, be it within the medical community. It's been really shared quite widely, so quite a positive approach to a whole system of action essentially. And I will stop there.
I don't think we want anything going viral, do we? That's the whole purpose.
Excuse the pun,
No,
yeah.
can I say it's really pleasing to see a presentation that isn't full of words that you then have reread back to you. So no, thank you for doing that, and thank you for outlining what the work is that's been done. And any questions or Vicky, Gracie?
Kirsty, I've got a wee list from you. Community pharmacy. So what are they going to be doing on Christmas Day? So
I've not seen the particular details, but as I said, whatever they do have in place, we will make sure that's shared around publicly, and with obviously the NHS 24, like I alluded to as well, and anybody other relevant parties to Vicky.
Okay. Discharge to assess. Have we any delays in relation to not being able to, get CAS or any of our providers? Or have we got people that are stuck in hospital waiting for discharge to assess?
Yes.
I will ask you how you guys solve that, because that's not an easy one, is it? And the third one was time of discharge. What have we done that's brought that down to earlier in the day? Because one of the things that was holding discharges up a lot was pharmacy.
Yeah.
So what have we done?
So there is the immediate discharge letter, and making sure things are done in a much more timely way, and it's not at the end of the process, it's starting things as soon as we can in terms of that discharge planning. So it's that discharge without delay principles that our teams are actually adopting, and also the fact that we've reopened at September our discharge line to enable people to sit and wait as appropriate and actually free up those beds. Yeah.
Gracie?
Thank you, Kirsty, for that very full overview of, for me, it's about what we're doing rather than winter. So some of that is business as usual, but also how we're preparing for winter. In terms of, the fantastic work that we have managed to do despite the crisis we are in at times is really refreshing. So really, thank you to all the teams involved. And I think this is a work around discharge without delay, discharge to assess, and all of that. I think for us, despite their best efforts, the next 6 to 8 weeks are going to be very difficult for the partnership. And we need to acknowledge that. And we
Absolutely.
need to actually be behind the people and say it with ease, because it's the reality. It's going to be very tough, but we have done it before, and we have prepared as much as we can. And yes, there are going to be community pharmacies open like they always are. There is a list of community pharmacies. We go the lists, and when I work in the hours that are there are normally one community pharmacy in each locality open. In terms of the acknowledgement of the spider best efforts, it's going to be a really difficult period. There is a real sense amongst frontline teams and all of us in terms of what that may look like. And for me, it's really a goal to kind of all teams to feel that clear and ease of communication and collaboration. So if we keep it that open and clear as possible, we will be, after February, hopefully, we'll be back to some degree of normality. But I just wanted to acknowledge, Andy, that the next 6 to 8 weeks are likely to be very difficult in terms of that increased pressure, not only for winter, but because we know around this time of the year, we do have more of an increased demand in services.
Thank you. Rebecca.
Thank you. First of all, taking nothing away from the massive amount of work that's gone into this, I think that personally, I think it's aspirational, some of it, because I mean, we look at the situation in housing. We've got a national housing crisis. Locally, we have, people staying in B&Bs, etc. I think if we were to use this as a template for next year's planning, what I'd like to see is much more of, well, this is the challenge, and the preventative stuff that should be sitting underneath it to try and get us, because the reality is, I think, basically, it's going to be far-reaching beyond 6 to 8 weeks. I think that the difficulty is that if we go into winter and we accrue some deficit in terms of actually we're not able to do something because we're busy doing this other crisis. We're not doing the day-to-day crisis because we're doing the winter crisis. So it just becomes an increasing challenge for us. The other thing that I would really like to see in this is, I think what we need to acknowledge, and I know that we all do, but I think it's making it a bit clearer, that without our staff, our teams on the ground, none of this exists. And I think for me that there needs to be something in the air about what are we doing for them over the winter? How are we supporting them over the winter? Because when you're out in somebody's home, having a conversation about what you're not able to provide them, and you can clearly see looking at them that they absolutely need it, it is devastating to those people. So I think for me, it's that compassionate leadership element, isn't it? How are we supporting our teams on the ground to get through this as much as anything? Thank you.
Anyone else? No, well, I think we all acknowledge that day to day, we had the conversation with finance earlier, day to day, we've got challenges. And I think that come this time of year, it just seems to exacerbate and become worse. And it seems quite unrelenting, because we're having increased demand throughout the year now. And it's about how we manage expectations, how we encourage people, some of the stuff we talked about earlier, take responsibility for themselves, how we can do some of that preventative stuff to means that they don't end up coming to the hospital or primary care if they don't have to. And I think, that's a responsibility on us all. I think in relation to what Rebecca said there about housing, clearly that's not an IJB or a health board responsibility. And the council have got it as arm's length now. I think there's work to be done, and there are steps being taken. And certainly I know the members of the board have been engaging with the council in relation to the development plan, and that we're engaging with housing providers as part of that. So I think that steps have been taken, but again, none of it deals with the addresses right at this moment. And I think that we have to be cognizant of that, but trying to manage it as best we can. Rebecca?
Yes, sorry, I probably slightly contradict. I think it is everybody's responsibility. I think it does sit within the IGB as much as it sits anywhere. And I think that is round about preventative agenda again. So actually, Nicole and I have discussed is about how we get my housing colleagues into social work and health early doors. So you're actually, when you're going into somebody's house and you're seeing that this person is clearly deteriorating and this accommodation is not going to be suitable for them in another 5 years or however long that is, it's for us to act at that point rather than waiting it to, for it to get to that crisis point. I think by doing that, it's about supporting each other in the whole thing. And I know that we do, and so I'm not suggesting that, but I do think it's everybody's.
Yeah, I wouldn't disagree, but I think some of those links become more tenuous.
Yeah.
And that's what I'm saying, that we can make decisions here that are going to directly impact on some of that. So, yeah. Okay, well, thanks for that, Kirsty. One last thing before we go. Professional to professional advice under primary care on slide 6. What does that mean?
So it's that signposting essentially, and being able to have those professional conversations, be it from a nursing discipline to a GP and vice versa, so that we've got those structures essentially in place.
Okay.
Can I come in, Chair? We're facilitating the availability of advice between professionals in terms of being able to speak to the right person to trying to find out extra information, or if it's going to change the management of a patient. So to trying to avoid going through the normal routes, we are just trying to facilitate that professional to professional conversation.
Yeah, if it means that we can expedite things, then yeah, it's got to be the way go. Okay, well, thank you for that. Okay, moving on then. We've got the Chief Social Work Officer's annual report for 23-24. The Chief Social Work Officer is required to prepare an annual report to a local authority and is required by the national guidance under all of the Chief Social Work Officer. This has been shared with members for that, and we should have Charles Rocks, but I'm assuming that you're going to be doing this, Rebecca?
Yeah, I'm Charles for today. Yes.
Rebecca Rocks.
I like it.
Yeah, thank you so much for that. I think just to say that obviously this details, within the backdrop of COVID, and it's about the positives as well as the negatives within that kind of that placement, if you will. So I'm happy to try and take as many questions or comments as possible, given that my expertise is more adult care and child.
Okay, folks. It's been circulated already, and know that you all have a thorough understanding and comprehension of it. But do we have any questions for Rebecca in relation to Stephen's report? Thanks, Mark.
I suppose it's not really a question for me, really. Every time you see this, it just shows you the benefit of what the social worker are actually involved in across a range of different disciplines. That it's not always in the social care arena, but it's much wider than that. And again, although it does paint a picture of some quite complex situations and some increasing demands as well across the region that we've got to contend with. So,
I mean, I would say to that the non-delegated functions are detailed within this, but I really believe strongly that if I stick my finger in a non-delegated puddle, the ripple effect will go right through and into the delegated space. So it is about, I think, trying to get a real understanding of what we're all doing and how how those interplay with each other as we move forward. Yeah.
Okay.
Thank you. I'm project to ask these questions again. It's probably like Valerie comment more. I mean, look at page 3 of the actual report, 3.6. Similarities with page 19. Political capacity to design services, the most commonly discussed challenge, budgets, and, you know, and the impact of both of each other is enormous, in terms of complexities of both, but not really understands. You look at the NHS, and we sort of see one thing sometimes, or see the bigger picture, not the complexities. So I think the work that you guys do here is phenomenal, and obviously I'll say that, I'm from the social work, so I was just going to say the council, but it is amazing what you do, and the preventative work that you do, feel, again, that we're talking about, that's a cultural thing, early prevention and things which is mentioned in the report, to stop things getting to the point where you need to invest. You're talking about finances, which is not the only thing, more and more money into things, it's actually phenomenal what you do. And sometimes what we do is focus on the negative, or which is natural, because you're trying to fix bits that are not working as well as they could be. Sometimes you're right, you need to focus on some of the positive work that's being done as well. So thanks for the work and pass that on to.
Oh, thank you so much for that. I mean, I think that, you know, that's really kind of you to acknowledge that, and I absolutely agree with you that the amount of work, it's not just within social work, the amount of positive good work that happens within all partners is absolutely tremendous. And I think that, you know, we need to really engage with the people who work with us, colleagues, to try, you know, to make sure that they understand that and to support them as much as we can, because, you know, without them there would be nothing really, would there?
Yeah. Okay. Anyone else? Okay. No. Thanks for standing in, Rebecca.
Okay.
We'll have to have a monitor on the doors, aren't we? People bring
Bosses,
take it
Willem
off.
comes in.
Classroom monitor. Okay, but thank you for that. We've been asked to note that, so we have done. Last standard item, developing a vision for general medical practices and general medical services in D&G. Tracy, Deputy Medical Director, will provide members an update of today's report, highlighting the main points of general medical services provided by GP practices across Dumfries and Galloway, the bedrock of National Health Service, with the vast majority of patients being assessed and treated by their GP with support from wider practice teams. That said, practices in Dumfries and Galloway, like those in many other rural areas, are struggling with issues of sustainability arising from recruitment, retention difficulties, growing demand, and increasing patient expectations. These issues of sustainability have been evident over the last 5 years in terms of the numbers of GMS contracts that have been re-signed by GP partners in Dumfries and Galloway. Is that resigned or re-signed?
Care survey were in Dumfries and Galloway. So no, all is lost, and there is plenty of good work. We are delighted with the opportunity to have some focus time to actually think and hear the views of our GPs, GP teams, and stakeholders to understand what is the vision for general practice in Dumfries and Galloway. We have never had that. indulgence in terms of that time to think about general practice. And we are just delighted. So thank you for the opportunity. In terms of the challenges that we have an aging workforce in the practice team. We got an increased demand and limited capacity. Despite our best efforts and the contract in 2018, introducing new professionals to general practice, we continue to struggle with meeting the demands. In terms of what we hope with this work, and there is a little bit of background in the main report around the need for us to think about our practices locally, and in terms of what we need to do is we need to be clear on the scope and remit of this work. And we have proposed a set of questions that will invite some contributions from GPs and GP practice teams and wider stakeholders. And actually, we will welcome also the IGP members' views around, how we go about this. But for us, it's really understanding where we are, what we're doing well, what are the strengths around what we're doing, but also identifying the gaps and seeing where we could maybe work and focus in terms of going forward. Looking at integration with other services, impact of technology, patient engagement, workforce development, service quality and improvement, promoting good health and prevention. We really want to be in that place. You mentioned earlier that men's health yearly appointment. Unfortunately, there is not a lot of evidence that the men's health yearly appointments make a huge difference unless those are targeted interventions. But we want to really be on that prevention space, but because of that crisis fighting mood or mode that we're always in, we struggle around that. But for me, really, is what is our vision for general practice in Dumfries and Galloway over the next 5 to 10 years? Although there is a sense of urgency, like we talk about this, of what we're going to do now. So some of that is really important that we also acknowledge in terms of the need for us to continue. We're doing a piece of work around what we need to do now that sits alongside this. I think they need to go parallel. I wanted to bring to the IGP members that we have consulted with clinical leads. We got clinical leads from our clusters, and we have also consulted with the local medical committee, and they wanted to really this collaborative approach. They welcome this. There were some comments around the questions, and we have offered a flexible approach. Some of the questions may change as we continue to engage with different stakeholders, just to understand what is that we're looking for in terms of that information. They also felt, the local medical committee, that perhaps the conclusions around fundamental change is needed was a little bit premature, because I think they would prefer to find out what's working, so we don't throw the baby out with the bathwater. They want to understand what's working well and what needs to change. So in terms of how this may look like, they really welcome that vision for general practice, and I think that's where we need to be thinking about the vision that we can maybe work together around that. So we're very excited. We're delighted for the opportunity, and actually, I want to fully acknowledge the support of the strategic and transformation planning directorate. We are finding that really helpful for us to lift our heads to think about the future rather than just in that reactive mode that sometimes we are finding ourselves in. I am open for questions.
Okay. Grace is up for questions. Who's got one for Ian?
That absolutely fine. We'll what we're trying to achieve here, basically, we're reflecting that. So look at it's 2.1. So we're asked to come and recognise scaling challenges, changes required. So it's getting the details what I'm trying to understand. I hope we can help explain that to them, but maybe there's others that may help too, because it is a proven proposal.
develop that initial direction. So after the initial direction, it goes into the detail, I think on page 8 after that. And it's quite complex. That's what I'm people do. So at box number 7, the full text direction. I think that's what we're agreeing in real terms, isn't it, when we agree that final direction. So I just wondered, do you consider that is, I suppose the main thing for me was how do we as integration joint board members, I'll definitely support this going forward, no two ways about it. Where's the interaction with us coming back? How do we monitor and see how this is working? 26, 27 is established a detailed associated action plan to deliver by 26, 27. It satisfies, plus the stabilised general mental services by improving it's the bullet points. I'm just wondering from your viewpoint, because it's your report, is that purposely you and coming back to the integration joint board? How do you communicate that back? You're not going to get the support that you need, budgetary, resource-wise and otherwise. Thank you.
Tracy, before you go, I don't know what Greg wants to ask, but certainly Gwilym wants to ask something that's related. And then I've got David, who I think is happy to respond to that point. So go for it.
It's related as in that when I look at the desired outcomes in the direction, I don't think they fully capture what's detailed in the text, particularly when we think about population health and the prevention and it feels like we should be looking for an outcome that captures that piece as well in terms of monitoring the impact of the direction.
Okay. David?
I'm going to ask David for that. David's.
He's just in a crossroads, hang on.
With me point first, so Ian, we're not going to disappear for long. We'll be back at the next meeting of the NHIB to present the answers to the questions from general practitioners, from the wider practice team, from the wider stakeholders, and proposing a scope for the NHIB to endorse at that point in time, and then begin the visioning work. We then plan to undertake that visioning work throughout probably the first 2 and a bit quarters, maybe 3 quarters of 25, 26. If there's a need for consultation around that future vision for general medical services, undertake that consultation and then bring the outputs of all that back to the NHIB towards the end of 25, 26, again with another direction to actually make the change happen. And to allocate any resources that are needed to support that, so long as that's affordable, what goes with Katie around that. So there will be opportunities for the NHIB to come back in and test the route we're getting to. I would also say that if at any point the NHIB, dare I say it, want to have a workshop around the scope, or indeed the setting of the direction, we're more than happy to factor that into the plans as well. We are talking about a workshop-based approach to the planning approach. Once we get there, that's been used really effectively in NHS granting. And just picking up on the feedback from the LMC around the conclusion, perhaps feeling a little bit stuck and not wanting to lose what's good about general practice just now, to understand that. So perhaps an appreciative inquiry type of approach through a workshop would help us build on what's already good, but recognising what needs to be improved at the same time. Well, you're absolutely right. We should have an outcome measure in there about population health, and I absolutely have it in which that's reflected in what we bring back.
Greg?
Yeah, I'd just like to start. I think it's great to see us start to discuss this, because I think all my time on the NHS board and the IGB, we haven't focused on this, but if you speak to most people on the street, it'll be GP services that we'll be talking about a lot of the time. So it's great to see us looking into this and a great approach to try and gather that evidence. I guess my question would be, given that you've said that 90% of interactions are with GPs, and what I've just said there about when you speak to people, they're generally focused on that. I think that interactions with people, interaction with potential patients, not just people who use it, but future patients, I guess, is really key. So I'm just wondering if you can say about how you're going to engage with local community groups, but I was just wondering, what does engagement look like? I'm not asking for a detailed plan, but I guess it's just looking for reassurance that we are going to pick up as much as possible what people's views are, and not limited to potentially like community councils and things like that, who sometimes represent a part of the population, not the entirety of the population. So just look for solutions and
So a bit of pragmatism around that, Craig. We have 2 months to come back to the IGIB with a bit of a plan for the scope. So we're going to have to go to the established groups to help us identify the scope. But once we move into the planning phase, and if there is to be a consultation phase as well, then absolutely we would cast the net much wider to try and engage those wider folks within the community who perhaps aren't the real heard voices, and make sure that they have an absolute opportunity to shape and influence that future direction and what that looks like.
so that's the kind of looking. So what you're saying there is that's still to be developed.
Correct. Absolutely.
But this initial group of questions that will be part of that to get these questions to the as wider group of people as possible.
So the initial questions are about setting the scope. So what I'm saying is, in order to do that within the next 6 to 8 weeks, we're going to have to focus on the groups that we know, and that's probably going to be community councils. We go and seek advice from around the scope. But when it comes to the wider discussions around what the future vision looks like, what the future shape and configuration looks like, then we need to engage with wider community members on that point.
No, that's helpful.
And you're right, for the need to reflect the voices of the communities rather than of a group of people. We haven't defined that yet, but definitely if we take that out. The other comment I wanted to say, Mark wanted me also to mention, he felt that he should also focus on the multidisciplinary team, and very much that is part of, and just to give us assurance around that, that's very much part of what we're planning.
I think it's very timely as well, because on the back of Right Care, Right Place, where we're talking about developing hubs within communities such like, then it's really key that we engage with general practitioners as a means of creating that cohesion and having that sort of joined up strategy and approach. I know you want to come in, but Rebecca had her hand up first, so if we can have Rebecca first now.
And Gracie, thank you so much for this, and I think it is really, it's timely and it's probably well overdue, isn't it? And I'm sitting in a very comfortable position in terms of social work is constantly looked at through the lens of, analysing what we're doing, are we doing it right, being critical, all of those things. So I think I can say that I'm well versed in how that goes, but I suppose from my perspective, and it's not a criticism of any one individual, but historically, I think GPs have tended to be resistant to certain things, and I suppose prevention, for me, going back to that prevention agenda again, is that our GPs, like other primary services, are the people that see the people. Well, we don't see them as much now because there's a lot of telephone contact, and I think we need to do something like in terms of that, in terms of the digital agenda, etc. But I think that there's much more that can be done at that level to prevent crisis happening. And I'll give you an example of power of attorney or things like that. For example, that if I attend a GP consultation with my mother and she's clearly, there's a deficit in her memory and you can see that there's a deterioration there, that is at that point that we need to be doing the work round about, okay, what do we need to get you to the place where you're not going to be sitting in a hospital bed delayed for 13, 14 weeks because we can't get a guardian order on you, etc., etc. So I really hope that we grasp the nettle in terms of the difficult things for GPs, because I also think that by doing that work, putting in that work, and it is very difficult on top of everything else, but I'm in a really comfortable position again because there's a constant ask from social work to do more and more and more and more. I think we just need to see GPs and other primary services just doing a little bit more around about preventive stuff.
Absolutely, absolutely, and I agree 100% with you, Rebecca. But the power of attorney is our responsibility. I'll ask anyone in here, have you done with power of attorney? So there are societal issues that we can all professionals can support. But in terms of when you enter healthcare, you need to think about, and the GPs, what has happened, actually the telecom consulting has gone really nearly back to pre-pandemic levels, but the world has changed in terms of how we use, and some people are actually preferring, some group of patients actually prefer a telephone consultation because it's more accessible. So anyhow, not for today, but You're 100%. I think the holistic approach is being lost, not for the lack of trying, but because the multiplicity of things that are being requested or asked or expected or needed and the limited time. So I think some recognition again, like we are thinking, what makes us a high impact and what is that we should be doing. At the moment, we are really busy with minor illnesses that we were in such a big problem before COVID, but because our health anxiety has gone so high after COVID, that continued to be an issue that we need to kind of energize informal with. Anyhow, I can just talk, clinical about everything, but I think it's a good point that holistic approach cannot be lost in your practice, and it's a bit the side because we're just task oriented at the moment because it's so transactional because of the lack of capacity.
Nicole?
Yeah, I think my observation probably, David, is just building on a few of the comments that we've heard, particularly just in that section 7 of the direction, because it reads to me that it's a lot about that kind of internal look at GP reviews from GPs themselves. And do we need to, whether it's the 25, 26 or the further year, just that, how do we get, it says there, engaging with the public and what to, with general practice and what to expect from them, as opposed to what do we expect from general practice as well in terms of the public and community services, because I think without primary care, it is the bedrock of everything that we do. And how do we get more of that learning from best practice elsewhere? What do home teams require of GP support? What do our care homes require of GP support moving forward, Gracie? And how do we pull, because that to me reads, might not be intended that way, but it reads very much that it's about, and not that I'm saying that GPs and the multidisciplinary team aren't a key stakeholder, but it doesn't really come through in terms of the strength of the other elements of that, in particular, just like adult social care, just like unscheduled care and winter planning, the learning from other areas that we could be bringing in and what that looks like. And also, again, not duplicating things in primary care if we've got services in third sector, etc., and those linkages. So just thoughtfully some of that wording in section 7 in the direction. And then my other comment is just given the complexity of everything that we've touched on, and I know Ken made the comment earlier, one of the things through unscheduled care that we are going to be looking at is not just that flow navigation and that being a kind of community primary care, unscheduled care element from urgent care, rapid response, and not that I think it changes this, but we just need to make sure that everything's joined up in terms of just all the different pockets of work, Gracie, because it is massive. But like everybody else, absolutely welcome this, because without primary care being at the, if we're not talking about primary care services around IGB, Viv touched on carers, it's similar. The scope of what primary care deliver for us in that early intervention, prevention and whole service delivery, you quoted 90% without it. So it is good to see it coming forward now to make sure that we're absolutely got it on the cards.
Are you want to come in on that point, Rod, or because if not, there's a couple of others want to come in.
This motion is to say that the wider perspective on primary care. We obviously undertook an awful lot of work through Time to Talk a couple of years ago, and that was literally, ground level, pitching up in high streets and supermarkets, asking people experiences, their perspectives. Focused at that point on community health and social care, but a very large part of that, obviously, as reflected by what was being said to Greg, but what people talk about first and foremost, a lot of that was about their experience actually accessing primary care and GP services. So not to talk about going forward, but I think we are in a fairly good position to start off with having had that work.
So what you saying, we could utilise that and then refresh it?
Well, I think it's certainly a useful resource for sure, and we made a lot of connections through that. And we can also, in terms of having those ongoing communications with conversations with the community, we have through these last couple of years of extensive engagement work built up a large membership now within the participation engagement network, and that's always something that's there available to tap into. I'm very grateful to everybody who's a member of that and does participate through that. So it's just to offer that kind of that background to where we are at the moment. We do have that to draw upon.
we got in the direction that we'll see a level of detail coming back that we can then further interrogate and ask questions about that. So I'm comfortable with that today. But the one ask I would ask is that because of the budgetary constraints we're under, we're talking about investing and disinvesting. I'm really keen to see the support through whether it's financial resource or otherwise. But for me, a key player for that is that because some people got A&E, you should rather than wait for them to fight with a GP, they'll just turn up the A&E and bypass the system. Quite often happens. So if we were to invest, I'd like to see like, okay, what's the cause and effect in regards to whether it's emergency services, A&E, whatever the kind of acute services. So the primary care, I'd like to see if we were investing this, there's a release of pressure on the secondary services. Yeah. I'd like to see if any further information coming forward, if that can be CPA's got an input.
I'm sure that'll be part of the considerations, analysis and what have you. No, it's Valerie.
Oh, no, it's fine.
Okay.
I was just going to comment on that point about investment, disinvestment. I think we do need to have a bit of a realism around this one in terms of a lot of the most of the GMS arrangements are nationally negotiated. So our ability to change payments or mechanisms to GPs as part of this is pretty limited. That being said, we're obviously in the constraints that we've got financially. So I think to be able to invest in somewhere, we would have to disinvest from somewhere else to do that. And the reality. So for me, this one is much less about the money, for want of a better way of describing it, but much more about what that service sustainability looks like and what the future, the longer term piece, and starting to shift things and nudge things gently in a different direction and starting to set that out intentionally. And I suppose I'm just managing a wee bit of expectations, because this is one where in my head, unless Gracie tells me otherwise, we've got less flexibility around that because of that way that GP contract is nationally negotiated. And that's not even, that's done through ministers, not through chief execs.
Very similar to dental sort of structure as well, whereby we actually have limited control or ability to influence data.
Yeah, and a similar vein, it was back to the whole point that was the Section 7 just now. The GMS contract is set nationally, so our ability to influence that is limited in terms of our sphere of influence around those participation in those national groups. There is therefore part of this is about enhancing people's understanding of what that contract is there to deliver. This work for me is much less about specifying those services into the future, although there is an argument around how we commission enhanced services being a bit more transparent in the future, a bit more tailored to local need. This work is much more about how we sustain general medical services, keep them, as Nicole says, as that bedrock of our NHS system local. So how they're configured, but also what their relationship is with absolutely their patients, but their relationship with the wider elements of the systems. Again, picking up on Nicole's point, that how they interact with home teams, how they interact with secondary care colleagues, and so on. It's specific defining that and working a way to improve that rather than changing, if you like, what they are contracted to deliver. And I think we just need to manage our own expectations a wee bit around the scope of this and our ability to influence that.
Okay.
I think one of the things that we need to do in relation to this is open up a wee bit about what we are doing. Because I know in my GP surgery, if you go into the waiting room, there used to be 30 chairs, there are now 8. And the 8 chairs are rarely full. And what the public are seeing in that is you can't get a GP appointment and the waiting room's only got 8 chairs. And the surgery's quiet. There's nothing going on. But what we know is that behind the waiting room, there is lots going on and the GPs are busier than they've ever been. But the public need to see that. They need to know that, there are only 8 seats in the room, but actually this GP's got somebody on the phone. This person's going through the e-consults. The next person's actually got somebody that's been with them for a 10-minute appointment, that's been in the room an hour. And I think it's that kind of opening up of, well, actually, why are people going to A&E when we know that they shouldn't? And what we're hearing and we're seeing on social media is that can you get a GP appointment? So, what else going on? But whatever we say here, if the public are seeing stuff on social media that they're not getting what they need, then they're not seeing what's going on. So we need to open things up so that they can see, so that they know that there is a way. I mean, I use eConsult all the time, and I've never failed to get what I need from eConsult. But there's a lot of people just won't use it. So they press number 1 and then they can't get an appointment. So we need to open up the, well, what happened to the eConsult? If you can't use eConsult, is there somebody that can, on another phone, that can talk you through eConsult to fill in the form for you? The public need to be involved in the conversation so that we're delivering what they need and they can see what we're delivering and not draw off to A&E because they can't see.
Bruce?
I was going to maybe at the end.
Okay, no
Yeah.
problem. Valerie?
Yeah, sorry to come back in, and it was just really kind of reflecting on the comment about the kind of desired outcomes, and David, I know you said you'll get one in terms of like prevention in there, but I think there's just maybe something to note that the outcomes in that are taken from the HACE surveys, are quite quantitative. I don't know if there is one that would actually talk about, you know, percentage of patients who are unable to look after their own care. It might be increased, it might not be increased. And I think it is a nationally constructed contract, and we don't have as much flexibility as we would perhaps like. I'm just conscious that when we issue this direction, you can't modify it for a year again. So I suppose I just maybe think that maybe there would be an aspiration to have something in there, but what that might look like, I'm not sure we can actually define in a quantitative way unless we can find something in the HACE survey, David, because the questions in there are to prompt what the GPs feel they can do in that preventive space, what should they be doing for the stakeholders to have that as well. So there's not something really concrete in there to say we can measure this or we can measure that. So I guess I'm just maybe just trying to manage expectations about an outcome that we can actually measure and achieve. It's got to be one that we can measure. It's got to be one that we can actually achieve within the constraints that we have.
So remembering this is a direction to undertake a planning process, then I think the outcome that we want to specify within this direction is that we are looking to enhance the capacity of general practice to provide prevention, early intervention, and improve public health. So it's a statement of planning intent that we're trying to capture in there. And then once we've done the planning process and we come back with the plan, then the quantifiable population health improvement might be a bit more obvious.
So we're discussing the process here at the minute. So right, okay. Now you said HACE. I'm going to have a hazard to guess that it's health and clinical excellence or something, is it? HACE.
I can't remember what we started.
Care experience survey or something. This is a survey that Public Health Scotland does, and actually it's very thorough. We had around 3,000 responses in Dumfries and Galloway, and it's all about general practice. And when I said that 3 out of 10 of the best scoring practices in Scotland, 3 out of 10 were from Dumfries and Galloway. So we go a lot of people who are very satisfied, 100% with the care that they are being provided by the GPs. But of course, we have the practices that are struggling. For me, this is not only about the wider thing. For me, it's for us to give general practice a time to think, to give us our general practitioners who are the leaders of the teams to think about where they are, what they have been doing, and what general practice may look like. Of course, with some limitations around the scope, because some of things are contractual, but actually, Ian, I think that's a good point. We have not had any real expectations about what maybe, but there are some locally enhanced services that we could think about if we felt that were relevant or important or came out of this work that could favor our communities. We don't know that yet. So although, and I can understand where Kate is coming from, I got some hopes around that too. We don't know, but really, I want to kind of, it has to be GP centered because the GPs are, and we're asking for the vision, and we're going to ask other stakeholders, but they need to be at the center of it. There.
Yeah, I was just coming back in, just on the back of what Vicky said, and I think it actually links to what Gracie said, because she mentioned, you know, some of the really good performing practices and things. I think, you know, in the experience, you know, examples that Vicky was talking about, I think what that led me to think is, well, what's my potentially, what's my experiences, and then they are very different. There isn't that range of options. So I think what this is going to flush to the surface is maybe some different performances in terms of happiness, people's satisfaction, patient satisfaction with local GP services. So this is an example where it's not just one centralised hospital, where we have one solution and it's like, this is it, this is equal for everyone. It could be that maybe through this activity, we identify best practice that we could encourage other practices to adopt. So I think it would be good if that was built into it as well, to try and recognise best practice and perhaps encourage as much as we can, with the limitations through contracts and things, others to adopt those, because I think we will find that people's experiences are very different, people's opportunities to engage with different, you can sort of whatever the availability of that or not is going to be very different for people across the region.
Ian again.
Thanks so much. I'll be quick. So when I was looking at point 7, I was looking at like the technology deployment, service delivery, refurbishment, development, replacement of facilities, strategic deployment of services where they're needed. Maybe my ignorance when it came to investment, disinvestment, that's kind of things. I thought you something like a wage contract, remuneration you were talking about. Maybe it's the whole picture. That's maybe my ignorance. So that's where those kind of stuff.
Okay. Okay, thanks.
I was just going to say, I mean, the contract entails both the payments to the GPs, but also the arrangements for IT and premises. And the responsibility for provision of IT and premises sits with the health board. So it's still part and parcel of the arrangements that GP have.
Okay, so we're happy with a few. Oh, sorry, I didn't say anything, sorry. Sorry, I can't hear you.
I keep walking.
I think the key thing for me is the introduction is 1.2, 1.3, but sustainability. I think the challenge that we seem to be facing in increasing Galloway is the need for or unsustainable. And a good point you made in this is about the GP being key here. So if we've got recruitment retention problems down to the GP, everybody, but GPs particularly, and then sort of gateway into health service in essence for people. What we need to do is involve them very much in how we improve services. And that might have an unintended consequence, a positive one in terms of attracting folk down here, because what we're actually doing is asking GPs what they need, what they want from GPs. So I think it's a really good move to do that. Absolutely essential, because I think the number 4 trying to happen, because I think challenges in 1.3, saying that GMS contracts haven't been sustainable, and the NHS board stepping in to manage that, and that's a major challenge. Not the only issue, but it's a key point here that perhaps hasn't been raised. We need to get back to a model where we have got sustainable practices with happy GPs and happy working disability teams, and also setting the public's expectations of what they can get from the GP. So you said one of the things that you mentioned earlier, which was really key to, was health anxieties have increased since COVID, and the effect that that's had on, I think, GP services, which I hadn't really thought about that until you mentioned that. I thought, why do people, that's a key issue that perhaps this will help resolve a little bit, because it might go into that once the scoping exercise has been done, which we believe that. Why has demand for GP services increased so much, and what can we do to reverse that trend or something? Thanks, Jeff, for letting me in.
Thank you.
Okay, on that, everyone? On that note? So we're going to just modify the direction, and then we'll bring it back and get it circulated. Okay, that takes me to any other business? No? Hello, Ian.
I'm very quick in the description of what I'm trying to achieve here, and I'll leave it in the hands of the chair through agenda management with the people that he works with. So I was at a meeting of South of Scotland Regional Economic Partnership, and I think this is relevant to the immigration joint board. as a part of that meeting, we actually had a presentation in the Galloway National Park. I think about what on earth that got to do with us. But anyways, so as the Nature Scott presented, and they said, listen, potentially 500,000 you visit Dumfries and Galloway annually. The screen came up on the Teams, Julie White, there she is in the background. And she got in and she made her point very clear, very strongly, very concise with regards to put the next 1,000 people in Dumfries and Galloway, the stresses that would have on an annual basis to the services that are being provided through health, social care partnership. Never mind 500,000. So it's put in that context. I think there's an integration joint board, so that we've been through a consultation process that ends on the 14th of January. February, sorry, I was going to say it's going to February, sorry. And I know the council's formalising a position, but it's something we need to have our eye on, I think, because that will, if that was to come to fruition, I personally believe the pressure that would put on the services. So whether it's health and social care partnership services that are delivered there, whether it's Scottish Ambulance Service, whether it's Mountain Rescue, whether it's a whole raft, we go on forevermore, transport, so on and so forth. That needs to be considered, but I think the integration joint board, and they are not consulting directly with authorities. I just think in simple terms, the community plan partnership board, the membership there need to be consulted properly, but Nature Scott are seen as that those organisations go to them rather than going up to them to consult like the statutory consultees. So that's it. I think we said I'll leave it to your capable hands.
No, I think you flag up a very important point, because with budget pressures and staffing difficulties, anything that brings additional pressure upon the services we're trying to provide, it's something that we really need to consider. I'm wondering, is it something that we can put to some of our officers here to give us an indication of that change of numbers? Now, I'm guessing that Julie will probably have some sort of figures mapped somewhere that would do that, but could we have a report coming back that would give us an indication of how additional numbers would impact and what, if anything, we could do to sort of mitigate against that?
I think that's a really difficult question to answer, really difficult, because you've got no idea what the likely demands of people who would come to visit would place on the system. And if it was about attracting new residents into the area, that's a much more stable thing to try and model on. But 500,000 combination of daily visitors and slightly longer period visitors, I don't know. I can go and speak to the team and see what we could potentially work up, but I think that's a really, really difficult.
Well, perhaps it's a conversation that needs to be had with Julie then, because if she's flagging this up, we need to know the context in which it's been done. Because what Ian's just put out there is likely to shape our thinking in relation to the national park, and we can't have that because, so we really need to understand the context in which that sort of comment's been made, and perhaps it should have been raised at the time. I'm going to ask Ian to come back then, Vicky, and then I think Rebecca.
She's very briefly, so Julie's definitely in coffee, and she'll share her thoughts with all the same. She was coming out to the wider partnership wanted to talk, and that was an agreement we got with her on the day. But to try and put it in context, from my perspective, is that even the 7 states capital pressure that put on the Scottish Ambulance Service and Mountain Rescue teams was incredible. That's one more aspect of the wider work pressure coming to the Galloway National Park.
I think it's definitely a conversation that we need to have, and I'm not sure around which tables or do we need to have around multiple tables, because actually when you said 500,000 people visiting the region, my first thought was actually that's 500,000 people. If we only got 1% or 0.5% people coming and thinking, I actually love Dumfries and Galloway, I would like to be here, I would like to work here, and we're sitting here talking about struggling to get professionals in. That was my first thought when you said that. So that from a positive, I think absolutely we need to have the conversation.
Okay. Rebecca?
Yeah, I would agree exactly with what you've said there, and I think also even I think it's an impossible ask in some ways to try and measure what the impact would be, because you'd also have to try and work out what how it would be levelled out by the amount of money that people brought to the area in terms of you know, local businesses, etc., etc. So I think it's a really difficult one, and I'm not sure. It'd be interesting to see what Julie's thoughts are.
Yeah, I mean, I think the actual figures are hard to quantify. What we do know in Dumfries and Galloway is we do have a surge through the summer months of people presenting the ED who are not registered with a GP because we do have quite a tourism industry within Dumfries and Galloway, which I agree with everybody's comments about the positivity of that, you know, and population released off it. But what I will do is take it in a board management team tomorrow with NHS just to have that discussion with Julie so that we can kind of highlight that in terms of, because it will be that ED accident and emergency pressure that's probably the greatest, because it is people who are not, they're not resident, they're here visiting, and we do have quite a degree of seasonality with holiday makers to the region anyway, but we can take that into the board management team.
Okay, thank you. Go on.
I was just wondering whether there might be some learning from the Route 500 for Highland Board. Trossachs National Park will be the next one, but that's 20 years in place. But Route 500 has been not very long now with a large impact on visitors.
Okay, well, thanks for flagging that up, James. I do think it's something that we need to give due consideration to. That being nothing else, can I just say thank you all for your contributions today. I think we've had some really interesting and lively debate, and just wish you all a very happy Christmas. Hope you have a good time over the festive period.